So Dr. Roy is our invited speaker for today. She's an assistant professor of cardiovascular surgery at Houston Methodist Hospital, and she's working as an endowed investigator in the Gerald B. Katz Academy of Translational Research. Her education and training was at the University of Toronto, where she obtained a bachelor's degree in bioengineering, her medical degree, as well as a doctorate in MRI of vascular tissues. Of course, she was also trained in vascular surgery at the very prestigious Toronto Vascular Surgery Program. Her interest is in improving care for lower extremity arterial insufficiency, leveraging her expertise in MRI and biomechanics. She is working to improve our tools and techniques through a better understanding of the pathobiology of the blood vessels and their interactions with our interventional tools in that abnormal tissue. Dr. Roy, we're really privileged to have you talk today on vessel imaging, morphology, and endovascular device interactions with the vessel wall. Thank you.
Thank you so much for having me. I'm excited to be here. My undergrad, it was in bioengineering, but it was materials specific. So this has been right up my alley. Very excited to be here. So I'll talk a little bit more about vessel wall morphology and how that can impact our device selection. I'm a 50-50 surgeon scientist, as we were talking about. And I think this group, we know critical limb ischemia, huge problem. Right now, there's two ways we approach it: percutaneous or open surgery. So BASc CLI came out. It seems like bypass is better in almost all of the major outcomes. But it did raise a lot of questions already. So the question was that it compared it to best endovascular treatment. But what does that really mean? So peripheral artery disease, the plaques are very, very heterogeneous. What it's made out of really varies patients to patients. And we have multiple different types of devices that are designed specifically for specific types of materials. But right now we can't tell these apart, and we treat everyone the same. One of the things that's been pointed out was there was an immediate technical failure rate of 15 to 20%. And I think that that is actually truly reflective of our clinical practice. I think we see the trials and it's 99% technical success, but really with these critical limb ischemia patients, this is a high failure rate. And the most common mode of failure is the inability to cross a lesion because it's too hard or too stiff to get through. So this is something I think we should be able to know in advance. Okay, so right now we're going in very blind where, it's like if you're going to drill through a wall, you need to know what it's made out of. If it's concrete or plaster or wood, you choose different drill bits to be successful in getting through that. If you choose the wrong one, you can create a lot of damage to the wall. And here we're talking about delicate blood vessels. And I think it's really key that we understand what we're getting through and do that with imaging. So the three basic steps of any intervention: we cross, we open, and then we want to keep it open. So talking about crossing, I think that that's something that we focus on with our MRI techniques and developing ways of identifying who is going to be at high risk of endovascular failure. And this is just a perfect example of one. So this is one of my patients. We did a CTA ahead of time, significant occlusion in the adductor hiatus, but not at all calcified. You present it, everybody thinks, okay, this is going to be super soft, easy to get through, no problem. So we do our RPVI attempt, which was the standard of care, just not too long ago. But it ended up being super, super hard, even though it's not calcified. We need to know whether we're going to go through butter or rocks beforehand. You can't tell on CT or other imaging. So we fail. And then we go ahead and do the bypass. We know that bypass after endovascular failure has higher failure rates, higher one-year amputation rates. So we are burning bridges with this approach. And then eventually she required an amputation, and we looked at the histology of the lesions, and it was in fact dense collagen. Now, she was entered into our study and had preoperative imaging with our MR techniques, but we were blinded to these for our interventions. And we see that it actually was a plug of dense collagen that you can tell on the MRI. And how that works is it's a new group of sequences called ultra short echo time sequences. And I'll walk you through a little bit of this, but right now, if you look at most of the MRI sequences, it looks like you can't see calcium, right? Calcium is a signal void, it looks dark. And the reason for that is calcium doesn't have much water in it, so less protons, and it's a very hard packed material. And because of that, the signal intensity decreases really quickly. So this is an example of that same lesion. And depending on when we're capturing the picture, we can see different types of materials with different contrasts. So here we're capturing it very early after our appels. And at this point, you know, the collagen and muscle, they both have relatively the same amount of signal intensity. When we image again at a regular echo time, okay, a little bit later, we see that collagen really drops off and muscle stays very similar, okay? And with that, you can use the signal behavior to really tell us what are the materials making up these plaques. And so we showed that that does relate actually in ex vivo puncture force testing, and we did a clinical study on that as well. And we're working on more generalizable techniques so that we can do this more. So then the next piece is, how do we open this? Okay, so we talk about when you are really dealing with heavily calcified, rigid vessels, when you're inflating balloons within them, you're requiring very high inflation pressures that causes barotrauma to the vessel wall, and you can have uncontrolled dissections. These are not always obvious on angio, we don't see it, but at least 70% of the time you're having these dissections, and that's thought to be related to why these interventions don't last. So a whole host of devices have come out for vessel prep, okay, and the goal of all of these are to either break out the calcium or core out the calcium so that the vessel wall is more compliant, such that when you do your ballooning, you don't have that same amount of barotrauma. You can do low pressure inflations, and the vessel is much more compliant. You know, none of these have shown benefit. But there's a big difference between different types of calcium. It matters if it's a nodule or sheet or fragments. All of these things will impact how successful a device will be. And this is an example of this is a segment of a diseased vessel, and it's a micro CT in 3 views. And I just wanted to show, just even along the length of it, how heterogeneous it is, how you have a lot of these vacuoles and areas of discontinuities just naturally within the vessels. So maybe that's why, you know, when we're just doing micro cracks or things like that, it may not be as effective as we would hope. But we want to study this robustly. And so we developed a way of imaging cadaveric legs and then testing devices in those legs. So this is our setup. So really lucky here to have a 7 Tesla MRI. This enables us to do high resolution imaging, 3-dimensional, non-invasive, right? So this is before we ever touch the blood vessel. We can see at 0.2 millimeter isotropic resolution what is the actual occlusion lesion made out of. Then we take the vessel to the whole leg to the OR, and we do it exactly as you do in our patients. So get through and through access in this case. We then will balloon it, either plain balloon angioplasty, or we'll do vessel prep with shockwave or orbital atherectomy. And then angioplasty, seeing if there's a difference there. And then we also have a control segment. And then we harvest it. We look at what did it do to the vessel wall on micro CT for the areas of calcium, and then histology for all of the other components. And so this was feasible in 14 out of 15 legs. One of those we couldn't cross intraluminally, so one of those immediate failures. But I just wanted to show you a little bit of the differences we can see with this. So this is a control specimen. You can see also either, an open or stenosed vessel. You're going to see this really healthy layer of endothelial lining, at least a complete layer of endothelial lining there. Now, when we did an angioplasty and just ballooned it at the nominal pressure, you had immediate recoil. It looked like you did nothing to the vessel wall. When we actually did an angioplasty based on getting it to a profile based on the angio itself, this is what we did to our vessel wall. And we had major plaque disruption. And it was really quite surprising because when you looked at the angio, it actually looked pretty good because your lumen's nice and big now. But yeah, we're really doing some significant damage to the vessel wall. This is what we saw with the shock wave so far, at least in this intervention. Not much difference. We did get a lot of recoil still. And then with orbital atherectomy, we saw that you had this preserved ring where you're not getting those uncontrolled dissections. But you also do see that you end up stripping the whole endothelium in the process. So what are the long-term implications of that? So we need to, one thing is the immediate effect on the vessel wall and understanding what a device does to a blood vessel. Another is, what does it do over time? And of course, that's the key question. And I think that this is a really exciting area for us because the MRI techniques, they don't require any contrast, any radiation, so you can safely follow patients over time. So we can characterize them beforehand and actually image them over time to see how the vessel wall responds. And I think that that will give us really necessary information to make our interventions more successful. So I kind of show this current standard of care. We have pretty high failure rates, treating everybody the same. I think that with advanced imaging, we can parse out who's going to be a good candidate for endo, who should be a bypass candidate, and if we're going to do endo, what's going to be the best device the first time. So thanks to a lot of people who contributed to this work, and yeah, thank you for the opportunity to present our work.
Wow, congratulations. Yeah, exactly. This is really thoughtful approach to something that, as I sort of said at the beginning, we've been taking a pretty blunt tool set to, and this is going to refine our ability to think about how we use our tools in a lot of ways. So we had some really good questions here. I'll kind of hit on some of these. Dr. Dardick asked whether or not an MRI techniques that you're using here could be done on our clinical machines, or does this require some sort of special machine like a 7 Tesla or a software upgrade of some sort?
So the MRI technique where I showed the patient study, so that one is like 0.5 millimeter resolution. And we're able to do that with stock sequences. So I developed this all in Toronto with prototype sequences, very specialized things. Here in Houston, don't have those, right? But we have stock sequences that can show us those. So you're not going to get the same level of detail, but you can identify who's going to be crossable or who isn't going to be crossable. I think that the 7 Tesla MRI, it's FDA approved. It is a clinical scanner, but I think right now the role of it is really getting an understanding of the vessel wall response more in a research standpoint. So
you used these different tools and looked at the histology in this sort of setting. We know that atherectomy, even though it sort of ends up looking better, still doesn't really move the needle on patency in the longer term. So what features of histology do you think we should be focusing on when we do this that might better predict those treatments that would be more effective and durable?
So we're looking at a few things. One is dissections. Is it the intima, media? How bad is the dissection? How much are we, disrupting the vessel wall? So that's one piece. But I do think an important part is the endothelial lining. So that's what I kind of pointed out there, because now we're creating, we're stripping the whole non-thrombogenic surface of our blood vessels. And I think that that's having consequences. So I think that that's something we're looking as well at the histology for.
All right. So we had a couple other questions regarding the current state of the art with regard to crossing, and whether we're actually burning any bridges when we do that percutaneous intervention from Dr. Schwartz. Do we really change the biology or the anatomy in such a way that it reduces long-term patency and limb salvage in these patients? Do you want to address that, or is that?
I think that so I wrote a paper on this called "Burning Bridges." So we don't know for sure, okay, but there are big studies in the the New England group, basal trial, so on and so forth, where they showed the higher 1-year amputation if you've had prior failed ipsilateral intervention. I think there's a few different ways why that might be the case. I think we distally embolize almost every time, and it's not visible. I think that we're making dissections and those kinds of things that could be uncontrolled, and that could be causing some issues as well. I just don't think that these interventions are as benign as we think they are, because angio shows you so little. You don't really know what you're doing to the vessel wall.
Excellent.